So thank you for the invitation. Thank you for my mentor and chief, Dr. Agresta. This presentation is about our experience and we want to talk about our experience and some consideration about our technique. We know that we review our data in a retrospective way and with a prospective database. And this is about our data until October 2020 to September 2023. However, the hospital was closed for COVID for a lot of months, so this activity is just until 12 months. But our laparoscopic experience come from 1992, and we have the time to standardize our technique. We know that we have some bias and some criticity because we are in a very small hospital in the north of Italy. It's a spoke hospital. We perform abdominal wall surgery, but not only, because we have also emergency surgery, and we try to perform almost 90% in laparoscopic way. We know that robot is probably the evolution of laparoscopic, but we have no robot in our hospital, so we continue with our laparoscopic experience. And this data is about 189 patients with almost 300 procedures. Majority of patients are male with primary inguinal hernia. We have 14 cases of recurrent inguinal hernia. And most of patients have light symptom in elective surgery, but also in urgent surgery, we can perform TAPP. And in some cases, we also associate other surgical procedure like cholecystectomy or appendectomy. And we are lucky because we have an anesthesiology team very skilled. So we start with the TAP and S block in addition to general anesthesia with very good results. Almost all patients stay one night in the hospital. And as we can see, according to the HES classification, we have we treated all type of size of inguinal hernia, and the majority in the majority of cases we found a bilateral hernia. So before surgery, during the informed consent, we explained to patient that if we should find a bilateral hernia, we can make the correction, the correction at the same time. Obviously, we have some complication. Fortunately, the are often in the first 30 days, and the hematoma is more frequent. Is the more frequent complication. In two cases, we have a chronic pain, and with the anesthesiology, we perform also a block with satisfaction. And we have two recurrence. Normally the recurrence is medial because probably we have no much overlap in the anterior to pubis. And now we continue with our experience also in abdominal hernia, like umbilical or incisional hernia. To standardize our technique according to the problem, and we try to planify the surgery to standardize it and to present the results. And we try to answer to give some fit, and we try to answer to the 5 question and the 6 question of the journalist. So for each point, we try to give an answer. So first of all, we know that laparoscopic hernia repair is not so popular. As we can see in this national analysis, we can see that laparoscopic approach start to increase, but is not always popular. And we have also a problem in Italy of the reimbursement in laparoscopic approach compared to open approach. We know that it's a more complex procedure than open approach. We have some problem with operative time and operative room occupation. So this is the reason because some center don't start with this laparoscopic, the TAPP, the laparoscopic TAPP, because it's too long, but we know that we need for a learning curve that it's longer than open approach. And we think also there are some limited laparoscopic indication because some surgeon probably not so skilled in laparoscopic approach consider the use of TAPP just for bilateral or recurrent hernia. But we know from the EHS, the European Hernia Society, and other guidelines that we can perform this type of procedure in all settings, like in emergency, in young, in obese, in women, in athletes. And for us, almost, the patient asks for this kind of surgery to have a rapid a faster restart of the daily activity because they have less pain and less complication. About our technique, we know that there are no difference in literature from the intra-abdominal approach and extra-abdominal approach for inguinal hernia repair. But we prefer the TAPP because we are more familiar with this procedure. We believe in the intra-abdominal exploration and in the diagnostic value also of the intra-abdominal exploration, because in some cases we found also other disease like GIST, and we can treat in the same time. We can combine other surgery if we find other hernia or like cholecystectomy or appendectomy. And we can use the same equipment that we use for other intra-abdominal laparoscopic procedure. And we also consider that TAPP is very useful for resident and for young surgeon to because we can perform TAPP step by step, and we can learn to reduce the hernia, to manipulate the intestine, to prepare the peritoneal flap or position the mesh. We can increase the intra-abdominal suture, and we have sometimes some young surgeon that can use this type of procedures to improve and to learn some skill that we can use also in other laparoscopic procedure. Normally we use 5mm trocar in this position. The first is normally in umbilical side, but it depends also from the size of the patient. We use 5mm trocars because for us is enough. So we use a 5mm optic. Normally, the pneumoperitoneum is low until 10, and after, during the suture of the peritoneal flap, we reduce the pneumoperitoneum also to 6 or 8, so depends. As we can see here, we use this type of mesh. It's very easy to introduce in a 5 mm stroker. Normally, we use 10 for 15 centimeter of mesh. And in the same way, we can introduce also the stitch. The nurse enlarge the stitch to can put in the trocar. And about our mesh, we use this type of mesh because we think, as you can see before, it's easy to position. It's very it's cheaper, and we have no problem during our experience. So we continue to use and you can also use a 50-450 if the hernia is very large. And normally we don't fix the mesh, but sometimes if in some direct hernia or large direct hernia, we can put a stitch to reduce the bulging and to reduce the hole, and we can fix the mesh with normally with the glue. About the cost, we have always the problem of we are in a little hospital, so we have not much money, and it's easy for us to use the same equipment. We can also treat bilateral hernia at the same time, and is time sparing also for patient. Using this type of trocar, we have less surgical trauma and normally less surgical complication like bleeding or incisional hernia, and we haven't to close the defect at the end of the procedure. And using this type of technique, we really increase our learning curve, and we arrive to perform also bilateral hernia in low time, and we can perform 4 or 5 procedures in the same operative room. Normally we don't fix, but also to try to reduce the pain, but sometimes if we need, we use the glue or some stitch. And it's cost effective also for the direct cost, because people ask to us to restart early the work and her activity. So also for this situation, we think that this procedure can be useful. I just thought about that, but also we need to combine the need for the surgeon and the need for the hospital. So also in a training program can be useful. And so in conclusion, we know that it's a long way to arrive to standardize the technique, but we think that this type of procedure can be really useful and beneficial for a small hospital like our. Also, if we haven't robot and we haven't a lot of money with if we have a good trainer and a good equipe, we can really optimize the time and the technique. And just to remember that thanks for Dr. Agresta, because we think with with a skilled surgeon and a mentor, this type of procedure can be very easy also. Thank you for the invitation.